Hi, I'm Nina, and I have the honor to introduce Miss Ophelia Dahl, who is Executive Director of Partners in Health. For nearly 30 years, Ms. Dahl has worked as an advocate for the health and rights of the poor. In the early 1980s, she traveled to Haiti to volunteer with an ophthalmic organization. It was in Haiti that she met Paul Farmer, and since then they have worked to bring health care to the destitute sick through co-founding Partners in Health, or PIH, in 1987. PIH is a nonprofit organization based in Boston, Massachusetts, and dedicated to addressing health inequities and social injustice. Ms. Dahl continues to serve as a trustee and executive director of the organization and has served as chair of PIH's board since 2000. Expanding on the work started in Haiti, Ms. Dahl has traveled to and supported the establishment of major PIH projects in Peru, Mexico, Guatemala, Russia, the urban United States, Rwanda, Lesotho, Malawi, and most recently in Sierra Leone and Liberia. Under Ms. Dahl's leadership, PIH has forged groundbreaking successes in treating the diseases of the poor and promoting health and human rights in areas of the world that have been ravaged by political conflict, poverty, and international neglect. The effectiveness of PIH's community-based model has been lauded around the world, prompting an explosion in requests to the organization to share its expertise and to play a greater role in global health advocacy. Today, PIH operates over 60 hospitals and health centers in these countries with a staff of 128 in Boston and more than 14,000 colleagues worldwide. Ms. Dahl graduated from Wellesley as a Davis Scholar in 1994 and in 2006 was chosen to deliver the commencement address. In 2011, she was chosen by the Boston Globe as one of the 3 Bostonians of the Year, and in 2011 was selected for the Social Capital Incorporated Idealist Award. A writer herself, Ms. Dahl also serves on the board of her family's foundation to honor the work of her father, the late writer Roald Dahl, and is engaged in philanthropic works in the United States and her native England. Please join me in welcoming Ms. Ophelia Dahl.
Thank you. Thank you, Nina, very much. It's good to be back. I love coming here. Any chance I can to come here, I do. And it remains a place to me that is filled with supportive, innovative, good thinking. And I have to say, having gone through the bios of all of you over the last few days, I can't tell you how impressed I am by how engaged you are already with so many different things. I mean, I was trying to memorize some of the things that you are already doing, and there's such a broad spread. It's really, really very, very interesting, and I'm deeply impressed and humbled by what you're doing. How's the week gone so far? Is it going well? I have to say, I looked at the schedule too, and I thought, I wanted to come to some of those. Have you heard from Professor Rosenwald already?
Yes.
Oh boy, is that taped? Okay, I would love to see that. I would love to see that. The other thing is, and one of the difficult things for me always in coming here is thinking about what specifically to speak about. And I don't want to give the same talk every year, even though I've been doing a variation of the same thing for many years. The mission of Partners in Health hasn't changed. I want to make sure that I'm talking to all of you, even though you weren't here last year or the year before, about some slightly different aspect of what it is that we're doing, which is why I titled this Beyond Ebola. And of course, many of the principles are just the same in terms of the work that we do. But the other piece is that I want this to be, as much as possible, a conversation. All of the years before, I've really enjoyed the questions and knowing what's on your minds and what it is based on a little bit of what you might know already. And I won't presume that you know much about Partners in Health already, but what you do know and what you might like to talk more about based on your interests. And you have such a broad range of interests already that I can't pretend for a second to know about, even a tenth of them. But I do know a bit about what it is to build an organization and that strives to deliver healthcare in resource-poor settings. I wanted to show with this first slide that just to put up our mission, which I haven't done before. It's necessarily a big and broad and encompassing mission. And I bolded a couple of things. as I was thinking about this, basically we are a healthcare delivery organization that works in resource-poor settings, and we, in order to do that, it's a complex mission. And one of my messages to you here today is that very little that is worth doing is not deeply complex and involves a long and committed engagement with what it is that you might choose to do across the world. So when people say that I've been doing this work for 31 years, in some ways it feels like a long time, and in some ways I'm actually just seeing some of the results of some of the investments that we made 30 years ago actually coming to fruition. So the fact that you are roughly at the same age that I was when I was lucky enough to be introduced to this work is interesting to me, because I'm already excited for what you might see in the next decade, and in 2 decades, and in 3 decades. This is a, as I said, it's a big mission. When I try to distill it down and I think about it's to decrease preventable deaths, reduce suffering, and to catalyze others to do the same. In order to catalyze others to do the same, you need to make sure that you're not only treating patients, but you're also training people, and you're also generating new knowledge. Some of the things that I'm going to say, they seem like neat phrases, and I'm going to keep saying this throughout our discussions together, and for however many years our discussions go on, the same thing, that these things sort of necessarily open an important Pandora's box. If you're really committed, if you're relentlessly committed to a mission like this, to serve the poor, to create health systems, that's what you're going to do. It's also because, for me, and I got involved in this work because I really wasn't aware of the fact that just how low the bar was and is in many ways. And that for me, addressing the gap that I saw between the way some people live and the way other people live, or the care that some people get, or the opportunity. I mean, you can replace these things with many, many different words, was deeply jarring. And I realized that as much as I wanted to, after I first went to Haiti to volunteer, as much as I wanted to race back to the countryside and the apple orchard that I grew up in, that I knew I wouldn't quite be able to do the same thing, that I could go back there, but I would always be thinking about what I'd seen, and perhaps the best way to address it would be to try to do something about it. So that was really it. It was just the idea that we live in 2 worlds, even though we all know that when you look at a map of the world, it is 1 world. But you can go anywhere else, and that's the thing about global health, is we call it global health. It's not the same as international health. Global health, and the reason that you'll see on the next slide that we have a map, and I realize and apologize that these are very difficult to read. These are the countries in which Partners in Health is working. And it has a little bit of context on some of the health statistics and that sort of thing there, but we can certainly give you this and you can see it. But none of this will be surprising to you. For example, in Lesotho it says 1 in 10 children die before the age of 5, and in Haiti 60% of births are not attended by a skilled health worker. So, but the other thing you'll notice is that we're working in the Navajo Nation in the United States. So it's the whole idea of, for me anyway, about global health is to address inequalities in access to healthcare, to address those kinds of disparities which take place, of course, all over the world. I think that in many ways the other thing to see about this is, although we have a tiny footprint in the world, and we've been going for a long time, and it feels like we're a big organization. We have about 14,000 employees at this point. Almost all of them are working in the countries in which we work. We have a staff of about 130 at this point, based in Boston and some other places around the United States. But the rest of the staff are all, back to that training piece and back to the employment piece, they all work in these countries. But it's still tiny. And it feels tiny to me. As an executive director, it still feels like it's not anything like enough, which is why, when I think about the growth and the trajectory of Partners in Health, I think that we need to think about this as a movement, and not about the cozy size of an organization. And we as an organization have grown exponentially in the last decade or so, which, again, separate conversation if you like, but that also is a complex thing when you start out as a group of 4 or 5 volunteers, and then you have 14,000 people and 120 people in Boston. It's different kinds of complexity and growing pains when you're trying to apply a mission like that. So we work in 10 countries, as Nina said. The collective, this is not necessarily exactly accurate, but the collective life expectancy in all of these places is probably about 55. People are living in just dreadful, dreadful conditions. Partners in Health tends to go into very rural areas because of our preferential option for the poor, we go to where there is least likely to be any services whatsoever. A lot of NGOs that work internationally will tend to work in capital cities for lots of good reasons, and some not so good reasons. I mean, capital cities are where you have access to electricity and housing and water and all of that sort of thing, not generally in the more remote areas. And the reason that we work in these, because I think, this doesn't occur to me because I've been so immersed in this, but if you were to look at this map, you might think that we had sort of, I don't know, put a blindfold on and thrown a dart at the different places and just said, oh, we'll go here. But actually, we first went here in 1983 and started working there because we were volunteers. We were not invited there. But every other place that we've worked, we've been invited to do something to address a specific issue. So in Russia, it was actually to address the terrible drug-resistant tuberculosis epidemic that was there in civil society, but mostly in prisons. We were invited to Peru, actually by a friend of ours who was working with a group just outside Lima. We thought we would be doing some water projects. It actually ended up that we uncovered when our friend, who was a priest, died of drug-resistant tuberculosis. We realized that in that community there would be an epidemic there. And so there is rhyme and reason, and most recently we have been invited to West Africa, which we'll get to talk about a little bit shortly. Yeah, I mean, I was just looking at my notes in terms of all of that, so that this is the area in which we work, and I know from looking at your bios, there's plenty of you who've already worked in many different places all around the world, and. So one of the things that we realized as an organization that was trying to address healthcare when we first started working in Haiti, the patients started coming. We responded to the request to build a clinic. The patients started coming. It was clear to us that it's not enough just to open a clinic, just to say, here the medications are here we've provided the medical facility and the equipment and the meds, that actually when we realized that when the patients started turning up for clinic, when we asked them what ailed them, a lot of the time they would say, I'm hungry, my children don't go to school, I have no shelter. And really as an organization, you can't be relentlessly committed to that broad mission and manage to ignore certain aspects of the rest of it when a patient comes to you and they don't actually have a specific medical ailment, but this is their ailment. You realize that you have to be able to address those conditions. This is, this is a poor excuse for a house. Many people. This is taken actually in Haiti. Many people live in conditions like this around the world, which I know won't be a surprise to you, but I was just in Haiti 2 weeks ago, and every time I make it my business to keep doing home visits, because one of the things that happens when you become, you're asked to do sort of more and more specifically administrative things as you become a leader. And I know that there are plenty of folks here. I see it with physician friends of mine. I know professor friends of mine who, start off teaching, and then you as a leader are lifted sort of higher so that you can have more of a view and influence over a bigger group of people. But you can stop doing the important stuff like going on home visits, and you very, very quickly can lose perspective. So I was there 2 weeks ago and continued going on these home visits, and every single time I go, I am re-immersed in what it must be like to spend time and have to raise children and live in these kinds of conditions. The next thing is just the food insecurity, and I know that some of you are already engaged in issues around food security. And this is a little fellow who actually I have an after picture of him, meaning after he received some food therapy, and he actually became much better, and all of the rest of it. But this is the kind of data that comes out of the places. If you're trying to provide medical care, and the people that you're providing medical care to are starving, whether or not you're, giving HIV medications. I remember this story about keeping this idea of providing healthcare broad, is that if you are able to offer somebody medication, but they have no access to water to drink it, or they can't take medications because their stomach won't hold it down because they don't have any access to food, you really have to find ways to do it. One of the things that we recently did after the earthquake in Haiti, we formed a partnership with Abbott, and we have built a Nurimamba factory, which is essentially a peanut butter or a fortified peanut butter, plum peanut factory there. And a lot of the time people talk to us about mission creep, whether as an organization that is based on, that's connected to providing medical care. How does all of this fit in? And the question is, it shouldn't have to be one organization that does all of those things. All we're saying is it needs to be done. You can't provide decent medical care if you have people who are malnourished or worse. And then again, some stats about water poverty, access to water, which in Haiti became is particularly dire, as you can see on this study that was done. So cast your mind to a place where you have in Port-au-Prince, for example, a capital city in a country that's an hour and... Has anyone been to Haiti here? Okay, so one of the things that happens is you get on a plane from Miami and it is about an hour and a half to get there. It's like going from here to DC. It's so close. And in Port-au-Prince, there is no municipal water system in the entire country. So there's any water that's there and comes out of the taps is delivered by a truck, is paid for. It is a commodity. There's no public health system that would support that. So you have people who are often unable to pay for water. They're drinking from dirty places. There's no place that the water can run. There's no way to flush a toilet that isn't an already contained sort of septic system that is your own in your own house. There's nothing that develops that. So of course you get some of the most terrible diseases associated with that, including cholera, which is the worst. There's the worst outbreak of cholera in the world today is in Haiti. And then after an earthquake, you have people who are, I drive past loads of built houses built by well-meaning groups that have their lovely looking houses, and they're right out in the middle of nowhere. And everyone says to me every time, why isn't anyone living there? Why would they choose to live in a shack? And it's because it's near a river, or it's near a market, or it's near something else. I mean, there's not a lot of thought is put into how you might rebuild for a group of people that lost everything. So you have these kinds of things going on. And as I was thinking about this, and again, I'm happy to give more context for how we got to this model, but as I was thinking about it, and back to that mission about what we're providing, these are the things that you need to provide for people if you are really interested in addressing healthcare anywhere. This is what we've got. We just take it for granted, right? You have a primary care, I presume. All of you have a primary care provider. If you get sick, you first call that person, and if you need something more complex, they send you somewhere else, and if you need something more complex still, they send you to a tertiary facility. In many developing countries, there is not any of this. There is certainly not this. There might be access to a primary clinic, but it's not connected to a system. And so the other thing I want to mention a number of times to you today is just this idea of a system. What it is to be in a place and live in a country in which there is a system for anything. A municipal water system, a medical system, because that's the key to the Ebola response, or to a cholera epidemic, or to an earthquake, is if there is a system in place, you will find that you can address any of these disasters, which is why then often disasters in some places are not disasters in other places. Or even when they are truly disasters, as we saw here very relatively recently with the terrible Boston Marathon bombing, we had a system right there. And so anybody who was not killed at the actual scene survived. And they survived because there was this extraordinary system that could take people from the horror-filled scene all the way to get them great care. There is no, it's not even in many of the places in which we work, it's not even that there's a kind of a crumbling system, there's no system. So the standards are seriously low and the gap is huge. Free healthcare and education, very, very important. All these things that we sort of tend to take for granted, this is a key point. Education, even a primary school education for girls, decreases the likelihood that someone will contract HIV. Just having girls who can read makes them less vulnerable and has massive effects on health outcomes. Community partnerships is an important piece of what it is we do, and it's actually the missing piece in this country. So if you have people who are in, if you have this system that, I'll go through it in a little bit, but it is the community that feeds into a clinic, that feeds into a tertiary hospital. Many people are either too sick or too poor or too cut off to be able to actually get to that first piece, the clinic. So you have to think about ways that you're going to bring the care into the community and have them taken care of there. For us and our partners in the countries, we started training community health workers. We made sure that the care was based in the community first and foremost. So we were able to train and employ and pay a whole group of community health workers. Most of those 14,000 people, the majority of them are community health workers. So they're receiving a salary for the first time, which can only be good. They're being trained, and they also act as critical liaisons in their own community, whether or not it's for a disease specific, so that it can be around HIV, or whether or not they're much more general and can be there. And you can't give them hundreds of households to take care of. You have to make sure that it's really very doable. That's a key part of what I think the secret is to healthcare everywhere. It has to be that whole system. Interestingly, here in this country, we have the tertiary hospital down very, very well. Many people go to a hospital actually for their primary care. Many people who are quite sick and shouldn't go to the hospital, that could be treated at home. If we could have a system of community health workers in this country, or something akin to that, it would be great. People should be treated in their homes for, major mental illness or diabetes care. There's so many different chronic illnesses that if we had that system, that people wouldn't feel that they would be better care, and they wouldn't feel like they had to keep coming into the emergency room for their primary care. Addressing basic social and economic needs, we've been through a little bit. I mean, this is a key part of it. You can't say as an organization, gee, we're a healthcare organization, I wish we could provide you with some help. So you can't. So when people come and they say, I have no money, you have to actually think about what that might be to provide loans, or even better at times, unconditional cash transfers. It's a radical notion, unconditional cash transfer. It actually makes, when Paul Farmer, our friend and co-founder, was on Korbel recently on one of the last shows in the last 2 weeks, I seem to remember he said on that, one of the things that we've done is provide unconditional cash transfers, and Korbel said something like, that is a terrifying thought. Some of my friends didn't know that Korbel was a parody. I promise you, some of them said, he was really not a nice guy. He really didn't. It was like, oh, really? You didn't know that? But in his way, he was saying that is a terrifying thought. Providing cash to poor people who have nothing is not done very often or very usually. But giving them jobs and training is even better. But some of the loan things that we see, some of the loan programs, they leave a huge portion of society out, because people that can be too poor to qualify for a loan, or too illiterate, or too something. So this is really trying to address that. And then serving the poor through the public sector. One of the things that we did at Partners in Health when we first started working in Haiti is we went ahead. It was we were there during one of the dictatorships. Democracy and transition of power is relatively recent in Haiti, and we were there with Duvalier as the president, the senior Duvalier, and then the junior Duvalier. And we just wanted to work under the radar, and we did. We wanted to keep our heads down, we wanted to work with our colleagues, we didn't want anyone to stand out, we didn't want anyone to get in trouble. So we built this first charity clinic, essentially, with donations, and many people came, and tons of people came, and then it became a bottleneck because you offer decent care, and you remove some of those barriers, including financial fee-for-service barriers, and lots of people will come. When we looked around and we said, this isn't possible. We can't get thousands of people a day into this 2-room clinic. So we went around and we actually looked across the countryside at what the public sector looked like. What do some of these clinics look like? What are people not going to? And it was terrible. The public sector was terrible. It was understaffed, underfunded, under everything. There were no tests there available, and there were fees for service. And so we said, why don't we partner instead with the public sector and try to make more robust the public sector, so we're not creating a parallel health system, just as you wouldn't want to create a parallel education system or a parallel anything. It is much harder to work with the public sector. It is much harder to work with a government than to be a nimble, small, flexible, do whatever you want to NGO. But it is the only way that you will actually change things for the long run. Because if you believe that healthcare is a human right, the only body that I know that can actually confer rights upon a population is a government. No NGO, no matter how, well-meaning and robust or arrogant they are, can actually confer a right upon a population. So that's what we started doing early on, and that is it's very key. And what we have found is that although it's difficult, there are, governments are not monoliths. There are people within governments that want to do things, and we've made great relationships with certain people at the district level and at the national level, and this is a key part of what we do. So I would say it's one of the principles. Since that first clinic was built in Cange in central Haiti, we have not owned any clinic ever. We buy the land or help buy the land. We often build it in conjunction with, and we give it to the public sector. So we give it to the community and the government, and it is a government hospital. So what happens at that point? If you have a system in place and then disasters happen, and a lot of the time I think people will think about NGOs as groups that actually work on disasters a lot of the time, cholera or floods or earthquakes, or, there are disasters because there are chronic disasters also that happen all the time. But really the only reason that you can actually respond to a disaster is if you have a system in place, which is why things are going not very well in West Africa for many people, certainly for Partners in Health. This is an image from, can anyone think about what this might be? Is this an iconic image in any way? When could this have taken place? It was after the earthquake in Haiti. And actually I came here, I think it was the first time, it was like 2 or 3 days after the earthquake, which is anniversary is the 12th in a couple of days, 5 years ago. And this was taken in the General Hospital in Port-au-Prince, and there are so many images from that time, but so many people, and many people lost limbs, but we were able to respond as a group to that specific disaster because we had been working there for over 20 years. We had built systems, we had supply chain, we had technicians, we had physicians. They weren't waiting for instructions from an HQ somewhere to be able to do that. They actually had everything in place. So there were many things that happened around that specific time, including the fact that it happened on a Tuesday. And most of our doctors were in the countryside. This was all located around Port-au-Prince. But many of our colleagues actually then came down from the countryside. We had over 500 people directly related to our colleagues or our colleagues themselves who were killed in this particular earthquake. That because of the conditions and the infrastructure, it shouldn't have been so. In fact, I think about 2 weeks later there was an earthquake of the same magnitude in Santiago, and maybe 4 people perished in that. 200,000 or 300,000 people perished in this very, very quickly. And if you drove around Port-au-Prince within 2 weeks, which I did, it was just as though the whole city had crumbled. So everything from the presidential palace to the civil service buildings to everything was just down, and many people, including whole classes of medical students and nurses, were just flattened in a matter of seconds. And so this is an image from that time. But one of the things that we have found as an organization is that disasters or specific events have often been inflection points for us as a group. They have driven interest, generosity, but also allowed us as a group to grow at that point. And well before the earthquake, we have sort of specific times in which we had inflection points for the work that we do. HIV was a major inflection point for us. Taking public sector money as Partners in Health was something we had decided not to do for a long period of time. We decided to do it in the year 2000 for a number of different reasons. We've built on these inflection points that have driven our growth as an organization, and it's been important, bigger budgets and geographic expansion, and our ability to take on and train more staff and to do more advocacy has been key. The reason that I wanted to talk about disasters is because of the specific disaster that is so publicized. Actually, less I've found this month than in the last few months. It's so interesting when you follow the news, isn't it? What stays up, what's considered pertinent for a while. And Ebola is a fascinating. This isn't like if I'd said to you, "What's this?" You'd know what this is, right? Like everyone would have been able to say. This was taken by my colleague, Beck Rollins, when we were together in West Africa about 2 months ago. And this was at an MSF treatment center, and we were going to them to sort of learn about how it is that they do this. And it was really an extraordinary visit for me. I'd never been to West Africa before. I'd seen quite a lot of disasters. And this was a crazy time. But what you see going back to the systems piece of this, what you see in a place like, this was Liberia. But what you see in all of these places is that there is no health system. They're recently recovering from civil wars. There is no system. And so you have actually more people dying of Ebola than from Ebola. So although the focus is on this and the dramatic response to it, to treat the treatment centers, and these treatment centers are quite elaborate. This was over many acres, and it has very specific sort of how you go in and how you go out, and the donning and doffing of all of this equipment, which again, having watched one of these people doff their equipment, 31 steps and being coached through it. So when I came back, and I was over there before Thomas, what's the last name? The first Duncan, was it? The first name of the fellow the Liberian who actually passed away here, and then the nurse who contracted it. I was there when that happened. And it was a very difficult time in many ways, because we knew at once that the nurse would not die. We knew it because she was already connected to a system. The reason that Thomas passed away is because he did not get through the system in the same, they didn't recognize what it was, and mistakes were made and all of that sort of thing. But we knew that the folks who had contracted it here would survive. And it was very strange and very jarring to be over there and to see so many people dying essentially of something called hypovolemic shock, which is just massive dehydration. This is a very scary, very contagious disease. Very contagious in a certain way, only if you have very intimate contact with the bodily fluids of someone who is very sick. But the standards of care that we have here are very, very different than the standards there. And so building up a system, making sure that we're not just this very impressive treatment center in a place like Monrovia or Freetown is necessary, and MSF is doing extraordinary work, and so are other groups who are doing that work, and we're trying, although we're slow and we're trying to catch up because we have no footprint there. The standard that is there is at the heart of this, and we have to find ways to make sure that we feel as though it's utterly unacceptable for some people to live and some people to die because of access to a not sophisticated treatment. It's hydration. It's hydration. That's what's keeping people alive, and it's complicated in that it's very hard to If there are any healthcare providers in the room, it's very hard to get a needle into a vein of a dehydrated person when they don't have a highly infectious disease. But it can be done. And I think that if we can raise our aspirations and say it's very important for other people to live and that they shouldn't be dying, I think it was, we quickly accepted that the rates for this, the mortality rates would be around 80 or 90%. And they really should be. We should say, no, it should be much closer to 20%, under 20% of the people who contract this. So this is an important thing. And then the more people dying of Ebola than from Ebola. So that means that there was nothing else taking place. So if you break an arm, if you have a traffic accident in Freetown, if you are a pregnant woman who needs to be to go through labor and delivery, if you need a C-section, if you have any complication, you are out of luck. There was nothing there, nothing available, everything had closed down. So I say this only to emphasize that I think it's really important to understand that although Ebola has the light shining on it, that if we don't rebuild the health systems there and attempt to do that, which will take years and years, then they will and we will be coming back always to treat and retreat these terrible diseases. So what we're trying to do there is to rebuild this. We've gone out into the countryside and we've gotten funds to be able to do this, but the funds are, as usual, sort of focused on the disaster. So we can get funds, and we've applied for them, although it's very complicated through all of the government mechanisms, to get funds to do this, to actually get those funds to say, and we would like to do essentially Ebola prevention, which is to build a health system. Very, very hard to get that kind of money. It's kind of crazy, isn't it? I put this up here because it was in Paul's article in the London Review of Books, and I put this up here because, this just seems obvious. I was with someone in Haiti a couple of weeks ago, and they said to me, I just feel like what Partners in Health does is just obvious. Like, of course you do that. Of course you treat people. Of course you stop the transmission. Of course you strengthen the health. Of course you. It's like it's obvious. And then when he came there, he said, now I understand that it might be obvious to us, but it's not being done on so many different levels. So what's interesting to me about this is you could take out Ebola and put in any other disease. You could put in HIV or you could put in anything else. These are the things that need to get done. But depending on what the crisis is or the disaster is at the time, that's what gets emphasized. But in order to do this, in order to stop transmission, for example, you need to do case finding. So to stop transmission, you have to have, it's a great thing to have an entire force of community health workers. Nigeria stopped their cases because they sent out a massive response into the community, and they did a lot of contact tracing of who had been in touch with various people. And it was really interesting to see how that happened and what a good job they did in terms of doing that, but how complex it was and how expensive it was, in terms of what the whole thing cost. I was lucky enough to sit down and spend a lot of time with survivors that we're employing out in these two countries, and sitting down and listening to the stories of some of these young people, particularly young people who contracted Ebola after taking care of their loved ones. Everyone, it was one of those moments where there was no doubt in terms of how this was transmitted. So, as I said, it was a kind of weird time because we knew what people were feeling back here. And I was sitting with people who had recently recovered from Ebola, very close to them. We were talking about this. It was intense. And yet, to know what they had been through in their 2 terrible weeks, losing people that they loved a great deal, being left with, in a place where there were people dying around them, often during the night with no electricity, some of them just on tarpaulin sheets, listening to the cries of one another and not being too ill to be able to hold the hands of someone else as they died. I mean, these were extraordinary stories, and one of the things that we wanted to do was to get these people who would then be somewhat stigmatized going back into society and give them jobs. And it's one of the first things that we did, and we've employed a lot of people in Sierra Leone particularly to do that. This is to emphasize what I was saying earlier. So this is the model. In the US we have this and we have this. And mostly in many countries in the developing world, you have this piece. You often, or you just have this piece. You don't have this piece, but you rarely have this piece. And one of the things that we've tried to do in the places in which we work is to build beautiful, big tertiary hospitals that have the kind of equipment that we would expect. They're often in community clinics here, out in not even the suburbs, but out in Western Massachusetts. There are things that you would expect to find in places like in certain clinics, like a CAT scan, for example. I mean, the CAT scan that we got in this teaching hospital in central Haiti that we built after the earthquake, the conversations we had to have about this CAT scan, which cost about $500,000, which you can't do anything. You can't. I don't know how many of you have had one, but if you have anything wrong with you, you'll get a CAT scan, just about. You'll go in, certainly if you have a broken bone, but if you have all kinds of other issues, you will be sent for a CAT scan. We were instead, and we were making the argument with some of the folks that we do budgets with, that actually to have so many people coming to a hospital and then have to send them to the place, the private CAT scan, of which there's one in Haiti, in Port-au-Prince, in the private sector, and to get people who are sick or have broken bones or feel terrible, get them transport down and then pay for that unreliable film and then have it come back. I mean, these are all things that, again, you should be obvious, but we fight about them all the time. We challenge each other and other people about them all of the time. These are not, for all of you will be making decisions as leaders in your lives about what it is you can do, and that's sort of part of what I want to say is make sure you have high aspirations. Make sure that you're not told that there should be something that's a little less ambitious for some group of people because it's not cost effective or it's not usual or it's a little bit too gold-plated. This is an argument that was used against our model for a long time. It's okay, but it's gold-plated. It's expensive. It's actually not. It's expensive. It's expensive not to do it. Have you ever seen that bumper sticker that says something like, if you think education is expensive, try ignorance? I mean, it feels like if you think providing proper healthcare is expensive, try not doing that. You can not do it and then realize that life is cheap and there are people dying all around us for want of a vaccination, an antibiotic, something else, and it's extraordinary. So we have to actually get to the point where we say one set of people can have this kind of care and another set of people has this kind of care. And we would have to then have this uncomfortable conversation, all of us. We say, is that okay? Is that okay? Is it reasonable? Because those are the conversations I have all the time, sitting in Freetown with really good, smart, lovely bureaucrats who are in charge of budgets who say, we'll do this, but we won't do that. And I think that we all are in a position where we can influence the thinking of others around this kind of thing, to be able to not accept that there should be this one standard and no CAT scan for these people, because CAT scan is too modern. Some of the things that aren't reaching people have been around for years and years. That water system piece, I mean, well, I don't know the year that John Snow took off the handle of the water pump in Broad Street, but it was at least 150 years ago, right? That's when we had the aha moment in London that said that cholera was being transmitted and we better get a system going, and he took the handle off and said, we've got to do it differently. 150 years ago. And we have people living so close to our shores, or anywhere indeed in the world, that actually don't have access to anything near that. I mean, you can go even further back. There are people living in positively medieval conditions. There are the kinds of rates of maternal mortality rates because of a lack of access to modern obstetrics all around the world. 300,000 women dying in labor over hours and hours and hours because people think it's too complicated to be able to get an OR up to create a place where, if necessary, people can have a C-section, or they can be followed up before or followed up postpartum during a risky time. That's a dangerously low set of aspirations, I think. I think you think so too. I know I don't need to persuade any of you. So what do you have to do to raise standards? What do you have to do to go from this, which is a picture I took in a pediatric ward in Rinkwavu in sort of central Rwanda, to go from that to that? What do you have to do to go from that to that? This is the hospital that we built afterwards. And, I don't think anyone would say, oh, that's okay. But I'm not sure that sort of, taking it to the next level where you have inpatient wards. This is actually part of a cancer treatment center that we started in with a partnership with the Dana-Farber and other people. And it's the only, I think it's the only public cancer diagnosis and treatment center in the public sector in sub-Saharan Africa. So, you know, the aspirations are not high. There may be one or two, but it's I think not. I think that's what I heard. And so when we started off telling people that we were hoping to, I mean, many cancers now are quite treatable. Some of them are not, but many of them are. Some of the childhood leukemias are very treatable. And when we started off by saying that this is what we wanted to do, we had a ton of people saying, really? Really? Cancer treatment in the developing world? That's what you are going to concentrate scarce resources on? Why would you do that? And it's because that is part of the burden of disease there. There is a huge number of people who are being diagnosed with different forms of cancer. And I say to myself, like, why would any of us say, like, there shouldn't be the Dana-Farber down the road? God forbid, should anyone we know or us, ourselves, get sick. But we know it's there if and when we do. That first picture I showed you, the slide, do you remember it with the woman being accompanied, the physician? That was in Rwanda, and that was, again, a picture of a young woman who had an osteosarcoma in her knee. And it had this profound thing that happened where we actually were out there with a colleague of mine here in Boston, a young man in his early 20s, and he'd been at work, he was playing soccer, and he had a pain in his knee, and he went and had some tests, and he was found to have an osteosarcoma, in which they would probably need to amputate the leg, and he would need to go through chemotherapy, and it's a wretched thing to have happen. And he didn't have to have his leg amputated, we had to have a knee replacement, and went through all of this, and about a year later came back, and we invited him to Rwanda to the opening of this. And while we were there, that young woman was escorted in. She was 20 or so, came in with her brother. Very difficult to walk. The Phil's sarcoma was diagnosed because he had a minor-ish pain in his knee. And this woman, her knee was like this, and she couldn't walk anymore. She did not end up surviving. And, you know, for Phil, it was a very profound thing. You know, why his was found because we have a system, and there is no system there. And so we just talked about what we would need to do to create a proper place where people could have pain management and chemotherapy and proper diagnosis and all of that sort of thing. I could go on for a long time about any of this, so I'm winding up right now. So same thing, stands like this is an Ebola treatment center in Liberia that was set up very early on. This is not in Liberia. This is the hospital that we built after the earthquake in central Haiti. It's a tertiary teaching hospital right there in the center. 350-bed hospital, 6 operating rooms, and a lot of good things going on there. So it's really sort of like, again, this is extreme. No one would say that's okay. But the things that I have seen and we have seen many times are not far from this. Not far from this. And we have to, what I'm saying to you is make sure that you keep your aspirations high, your standards high, and think about how something this beautiful, you know, could be important, because you know, it's not possible really. Who would want to live in a world in which there are these widely different standards? And this is it from the air. It's actually one of the largest. I think it might still be the largest solar public project in perhaps the Western Hemisphere. But you might know more about that. Occasionally I am prone to hyperbole here, and I may not be exactly, but it feels like it. Doesn't it look big from the air? It's a very big, very impressive one. So these are all solar panels. And this hospital, this hospital was built, and you know, it feels like it took us, you know, in some ways I feel like it took 30 years. I actually met Paul Farmer on one of those little hills there 31 years ago, and it's total coincidence that we did not build this because we met there, but it's one of those things where occasionally when we're there, as we were a couple of weeks ago, we sort of turn around and we're like, oh, that was the place. But this is some housing, these administrative buildings. This area here is about to be a new pathology lab because the one that we built in here was not aspirational enough. It's one of the few things, we made this bigger than we hoped we need it, but the lab we built too small. We needed to make sure that we could do the kinds of tests and have the kind of training take place so that we don't need to send all of our samples and pathology samples to Boston. So I was meeting with a great partner of ours, Larry Schulman at the Dana-Farber last week, about this pathology lab, and he said to me, he said, we're bringing up about 400 samples a month to be tested here at the Brigham and at Dana-Farber. We have great partnerships. They do it for free. It's extraordinary work. Some of this can be done by telemedicine. Some of it can be done by just training people in the right places and making sure that we have that supply chain, so we have the reagents we need. But, it's like, can you imagine a place in which you have 400 pathology samples needing to come to Boston because there's no way to do them in a country that's down the road from us, as it were. So, this is what we've got. And, as I say, making sure that this is part of the system when this was missing. And, I think if you'd said to me 31 years ago, do you think that you'll end up building a hospital this big and this ambitious? And let me say, this is cheap. This is cheap compared to, healthcare financing in this country, I would love to understand it more, and I plan to make it my business to understand it more, but it is complicated, is it not? Do you understand all of the nuances of how monies get spent and what things cost versus price and how that all goes on? It's very, very, very opaque to me. But when you hear about actually how much things cost, and you hear about, I know because we're close friends with people in the medical world here in Boston, you can't build a bathroom at the Brigham, truly, for what it cost us to build this, which is probably about $20 million to build this hospital. That's not a lot of money by most standards. But you can't also just have a hospital. You have to have the whole system. I just want to make that clear. A lot of the time, that is not necessarily clear. So these kinds of wins over a long period of time, very transformative and very, very, very important for us to see. Last slide is just another different part of the world, but an important hospital as well. This is the hospital in Butaro in northern Rwanda on the border of Uganda. And this is another hospital we built. I kind of like it because I just think it's beautiful. And many of these places are often not built to be beautiful and provide dignified places for when people are sick. President Clinton came and actually opened the cancer unit that's in this hospital. And he said that as you drive, it's a beautiful drive from Kigali all the way up here. And he said that, this is the kind of place that he wouldn't mind being sick. It feels like a place to heal. And a lot of the time, I think that making sure that we're concentrating on the fact that it's a beautiful place to heal is very, very important. And then I'm going to end with a 1-minute public service announcement, which sort of drives home some of the points that I was making that some friends of ours made recently. Thank you. I'd like to open it up to questions and a conversation. Yeah.
Hi, I'm Allison. So I think that we would all agree that for those, who are dying in these unfortunate, terrible conditions, we should absolutely help. But I'm skeptical of, or I guess I am wondering, what authority do we have to go in and say, well, you need this system, and how can we make sure that in proposing a system, we're really involving the members the system is meant to serve, and that those members of the community actually play a role in establishing that system to make it sustainable.
Yeah.
So just your thoughts on that.
Yeah. Did everyone hear the question? One of the things that I've done when I've spoken before is to give a little bit more background about what Partners in Health has done and how it goes into places, and the invitation is part of it. But the involving the community in the questions about what is needed there is a very critical part of it, and making sure that that's not the case, because you're 100% right. I think that a lot of the times NGOs, which are a group of highly unregulated and groups, go into places and decide what it is that's needed and just do it. And that it doesn't work well at all. It doesn't work well, and it's offensive and all sorts of things. But going in and working well and at the invitation of the government, the local government and the national government, and having them assess what help is needed is very important. We that's what we have done in each of the places in which we have gone. It's not, I'm suggesting to all of you that health systems are needed. we haven't met anyone or a group of people in any of the places where addressing that gap, the burden and the gap, has not been part of what they've asked us to accompany them in doing. So I think it's a key component. And when we were suggesting in Rwanda that the community health workers needed to be paid, and we felt that that was essential, the government of Rwanda, the Ministry of Health, said that that was not sustainable for them and they didn't want to. So we did not do what they asked us not to do, but we did suggest that we do a study to see what happens if you pay one group and don't pay another group, and do it in what they had suggested, a cooperative way. So we try to do that, and I think it's absolutely key. Sure. Yes.
Hi, I'm Maria. So I was just wondering, when we talk about the systems that are in place or not in place in a certain place, we were talking about the other day about good governance and how a lot of times we assume we have a blank slate when we enter a country or when we're dealing with any crisis. And in these situations where there is no system in place, I was wondering if you consider that as a blank space, blank slate. That was a song. So I was just wondering if you consider that as a blank slate, or if you consider that that blank slate as making it easier or making it more difficult, or if there really is no blank slate that you're starting out with.
I think there's no blank slate, really. I mean, to Alison's point, if you're working with already a community that feels that though there is, I mean, there's a blank slate in that if you go to some of the most remote corners of Liberia, there will still be a health clinic of some kind. It may not have anything in it, but there will still be something there. So I think there's, in terms of, so I'll give you, I might address this. So the blank slate part of this is if there's nothing there and you can build from scratch, rather than try to slot in different bits and pieces into a system that could be partly already there. Is that what you mean, or are you talking about governments?
Well, I guess both, because you're saying that government is so crucial to
Yeah.
also playing a role in
Yeah.
how the system gets set up.
I mean, governments are, I think that creating relationships within governments are very important. I'll give you an example of something that we addressed when we went to Peru. As I said, we thought we had been invited in to address the dearth of water systems that were there. So we had a $30,000 stipend for that, or allowed budget for that, to replace some water pipes in this squatter settlement and outside of Lima. And actually, when we found out there was MDR-TB, we realized that we could ignore that at our peril and know that you'd put the water system in and people would die of drug-resistant tuberculosis, or we could do both of those things. But Peru is a very different country with a medical system already in place, although it is flawed, as ours is too. I mean, this is like, there's not a medical system that is perfect, although there are some countries in the world that have far, far better medical systems than others. So in Peru, we were asked to, we realized there was this problem, and then we had to address the Ministry of Health to say, how do you tell a group of people that there's a problem when they're insisting that there is not a problem? And so it took us a long time, and I think over 12 ministers of health, for us to try to convince afresh each time that there was a massive problem with drug-resistant tuberculosis, and we would have to, we would accompany them in making sure that the treatment regimen, which was empiric, so they weren't testing the resistance, would need to be done. And they kept saying, no, that's not what we want. That's not what we want. So you have to be very persuasive, but you have to accompany in the right kinds of ways if you're going to be good at what you do. So you can do it in a way that many people do it, which is to say, well, we insist on doing it, and either the country will wait until you've gone, or you will run out of cash or heart or patience or whatever it is, and you'll leave. But it's the sort of the public sector piece of this is actually getting on board and wooing people and cajoling them and becoming partners with them and making sure that they can own it. So there was not a blank slate there at all, but we were able to do that. It took a long time, which is the other message in this. It can take a long time. Does that answer it?
Yeah.
Okay, good. Yes?
One thing that's come up in a lot of the talks, and I think also came up in yours, was the complexity of these problems. And I know one thing that Partners in Health health focuses on is the preferential treatment of the poor, which I think is very important. And so, but when you go into crisis zones, how do you think about the allocation of resources, of your resources, especially with an eye towards sustainable system development? When you have, it seems, so many interconnected pieces, like in Haiti, there are a lot of institutional problems as well as health concerns. How do you preference things?
Yeah. I mean, the way that we have done it is by looking at what the gap is. So if there is a specific or a burden, first of all. So if there's the burden of disease in one place is HIV, we have tended to put resources towards some of the greatest burdens. In a place like Lesotho, because of its altitude, there's not going to be a lot of malaria, for example. So we try to be very specific to the place that we're working. A lot of the time, when we talk about limited resources, which of course there are finite resources, but we have often found that it is used as a conversation closer rather than a conversation opener. And so it is complex in the sense that it doesn't do any good if you are speaking with people who say, but how will you allocate these resources? There's only a certain amount of resources that you've got. How do you do it? It's not useful if I say, but we can get more money. But the truth is there is a lot of money out there. And so it depends, that's where the ambitiousness of a budget should come in. So, a lot of the time what we have found is when people have told us there's no money, there actually has been some money, or we have found some more money, or we've found a way to leverage it, or we've found a way to bring more people in. But, even that being said, we're having painful discussions all the time about what it is that we're trying to do. And I think that if you keep your eye on that kind of a broad mission and say that there's a system that we need to build, and that system is composed of community-based care and clinics that feed into a tertiary hospital, and you insist that you have to, and what are the components needed for that system, then it's that platform, building that platform of primary care that will allow you to innovate on around other things, other diseases. You can't treat cancer if you don't already have a platform of primary care. You can't treat HIV, actually, without doing that sort of thing. And the same thing is true of crises and emergencies. So if you didn't already have something there, you can't then, which is why you have to build tents and start afresh and only treat Ebola or only treat cholera if you don't have these other things in place. So it's an ongoing struggle for us. We haven't nailed it at all, except that we try to sort of really think about what people mean by sustainability. Sometimes we're a little bit provocative about that in terms of, we talk about what about sustaining our own interest and our own involvement in this work. Let's talk about sustainability in terms of how we can stay interested so that we don't move on to the next thing, or that funders don't move on to the next thing, because that's the other thing that's happening all the time. Results. We need to see results in 6 months. Now, the impoverishment of a community can take 100 years, but people want results. Funders want results in 6 months, which isn't always a bad thing. I do think results need to happen, and I think that NGOs can't be flabby. So that's the complexity piece, but I don't have a really good answer, except that I think that you have to have priorities, but there has to be non-negotiables too, because you can't. If someone says, "Well, choose what you want. You can either have the tertiary hospital, or you can have the community health workers," we'd say, "No deal. We have to have both. Maybe we have to do each one a little bit smaller, but you have to have both of those things. Oh, and by the way, you have to have at the clinics as well." So it's really kind of our ability to persuade people that it doesn't have to be this or that. Sure, yes. And then I'll go out to the fringes.
I'm Betsy, and something that has come up in other lectures that we've had and a couple of readings is the problem that can be created by having goals that are too overreaching or too aspirational, particularly in Maria already brought up our good governance talk, and also talking about the development goals. If they're too broad and not realistic for certain places, then that can perhaps be more damaging than helpful. So I guess my question is, how do you reconcile the power in being creative and imagining a better future and dealing with the practical realities, I guess?
So I don't think that the problem is that we are going to be too ambitious or too aspirational. I mean, you guys might be in this room, but I don't think that that's generally the problem in the world. I think that, looking at all kinds of places that I see, and you've probably seen, that's not. I think the danger is that people will tend to have low aspirations. And the confounding thing is, as we are socialized for success, as we all, I presume, have been, so we actually have it within our power to make a great deal of change with a group of people. And yet people will try to persuade you. And of course, Professor Moriarty was making lots of different points, I'm sure. But I don't think that is going to be the issue. So I would say that if you're not biting off more than you can chew as an organization at a time when the disparities are so enormous, then you're not doing enough. Better to bite off more than you can chew and fail and understand why you are failing than to have a standard that you can meet that will be this far below what is actually really needed. Because if we did what was needed, if you really actually were able to accomplish that, I mean, we need, looking at what's happening in just those two countries with a health system, you should be ambitious, which doesn't mean to be reckless. I don't mean you sort of go in and say, we can take care of this and we need $1 billion next week. And it's not that. But it's just that well thought through, ambitious goals and making sure that we're biting off more than we can chew is something I relish all the time. And yet always, as you scholars of sociology and Weber will tell you, that the iron-caged bureaucracy is around everything. And when you start off as a tiny little organization that can do anything you want, no trustees, no board, we had nothing. It was very easy for us to move. We had mostly one funder, an angel investor. He was terrific. And we'd say, well, there's a TB epidemic in Peru. I know we thought we were going to do this, Tom, but actually we have to address this. And he'd say, okay, how much will it cost? And he's like, it's going to be about $10,000 per patient. Okay, how many patients? We said, just maybe 3 or 4. We just need to prove that the model works, and then we think we can leverage more money. And we went up to about 10 or 15 patients in the first cohort, and of course it did work. We did show that actually that kind of non-empiric treatment worked. Testing for drug sensitivity was the thing that worked, and we knew it would, and it is more complicated, and it would be more expensive. But that initial investment of 100,000 or so actually enabled us to leverage an enormous amount and prove all kinds of points with our partners and get prices down, prices that were already should have been down because they were generic at that point, but no one was paying attention, and create partnerships. And we've actually leveraged with lots of other people hundreds of millions of dollars towards different specific things. So having that freedom and flexibility to do what you need to begin with is really, really important. But if we I remember that time, even though it's a long time ago, very, very well, where I had some people saying to me, but wait, you've got other people, you could have spent our whole budget was like 200,000. You spent 10,000 on one person for one treatment in tuberculosis? How many people could you feed in Haiti for that? So, these were tricky times, and they still are, but we're doing it on same kinds of discussions, always robust, always difficult. But sort of it was that initial investment that allowed us to do it, and we couldn't have done it if we had had a very specific board of people around us who'd say, are you out of your minds? You think that that's what you should be doing, spending that much money on it? So it's a titration in many ways. How do you not get reckless? How do you stay ambitious enough? How do you stay creative enough? And for me, I keep checking. I don't trust myself sometimes, particularly I think when you're not proximal to the people that you're thinking about or making decisions about. That's a key part of this. If you are in an office in Kigali and the people that you spend time that you're making decisions about are far away, or you're like me a lot of the time in Boston and making decisions about whether you spend money on a pathology lab, go and visit. I don't trust myself if I haven't been traveling for a little bit to make these decisions that seem very rational, but not necessarily ambitious enough. I will not answer with such a long-winded way. I'm going right out to the fringe over here on the right.
Hi, my name is Bridget. One of the questions that I had is about thank you. It's about an ongoing debate in the medical field about sort of
relative inequality in that some pharmaceutical companies sort of patent their medicines and their sort of recipes for cures so that they have incentive to research and create more medicine. But in so doing, it causes like an inaffordability for a lot of people. And I was wondering if Partners in Health has a particular stance on the matter, whether or not you think the balance should be swayed one way or the other.
Well, probably unsurprisingly, I think that medicine and health is a right, and I think that if you have, I think I even read that someone was involved in some of this research or has been engaged with some of the companies doing, maybe it was diabetes, but I'm thinking about some of the new hepatitis drugs that companies have spent an enormous amount of money on the research and development. I think Gilead spent about 11 billion on the research and development of the new drugs to treat hepatitis C, which costs, I think, 80,000 per treatment, $1,000 per pill. But unlike all the treatments before, which are horrible and toxic and don't cure and take 2 years and make people feel terrible, it's a no-brainer in many ways. There are ways that we can foster discovery and development and at the same time also make sure that these drugs get to the people who can't afford them. And few people can afford an $80,000 treatment, and some people would feel like it was cheap. I mean, it's a crazy world that we live in. But given that hepatitis C is a disease that affects mostly people who are on the poor end of the spectrum, often intravenous drug users, I mean, that was a lot of scratch that they put into a drug that is mostly going to be used for poor people. So there has to be a plan in place. And I know that I've been following a little bit some of the debates about whether that is necessary. And I don't think that of course people have to be incentivized to sort of come up with new things. I just think that we have to have an equity plan. We have to have an equity plan that makes sure that some people don't get access to it and other people don't. And I think that we can do that through all kinds of different ways around universal access and having some people who can afford to pay more for certain things and some people who can't, to subsidize those who can't. I think that there are innovative schemes to be able to, I think the Clinton Foundation has been involved in price reductions. A lot of these drugs, some of the ones from the HIV drugs and various things are now that initial investment in paying for HIV drugs, we don't pay for an HIV drug anymore because of an innovative scheme in which drug companies that were horrified, it was Brazil who started taking drugs that they shouldn't have off patent, technically shouldn't have, and just said, we're going to do it anyway. So there are ways to do it. I don't have the answer for it. I'm hoping some of you do, because that is something that if you put your minds to, I know that we can find a way to do that. But I think that public goods, there should be public health goods for public use. I'm going to get, all right, yes, Zoe. And then swinging back over this way.
Thank you so much. So returning to the idea of the blank slate, I spent some time in Ndasi Bay, Madagascar, and I was following around or observing a midwife there. And one of the really interesting things that I saw was the response of the clinic and the doctor at the clinic versus the midwife. And the doctor at the clinic really wasn't very fond of midwives, because he said kind of jokingly, like, well, they're better than I am. And what he meant by that was they've been trained for 30 years in an apprenticeship to do things, as complicated as, turning a baby, and things like that. And so when you're going into these communities, are you considering the traditional healers who are there who have this expertise, though it might not be Western expertise? Yeah.
Very, very much, and including those people who have served in a role as traditional healers, as traditional birth attendants, all the way along I think it's very important to do that. In some cases, we've given traditional midwives, more training and more tools, and then we've given them because they stand to lose their livelihood if you suddenly have a tertiary hospital that's encouraging particularly women with complications to come to the clinic. So we've actually incorporated them in and engaged them in the pre, during and post care of the mothers, and including giving them an incentive, paying them, so that instead of like getting paid just to do, which they would get paid by the family to do the delivery, they actually get paid by the local government to bring the patients in. So we've tried to do that. You know, sometimes it can be harder with people engaged in traditional practices that are, I'm thinking about leaf doctors and that sort of thing. But even with them, we've managed to engage them. A lot of the time they've gotten sick and they've benefited from some of the things, and then we've found ways to bring them in. And yeah, I mean, it doesn't always work, but that's what we try to do. Yeah.
We're going to have time for one.
Oh no, don't make me choose. Don't make me choose. You choose.
Someone who hasn't asked a question yet. Gabby.
Hi. So you spoke a bit about how it's really necessary for NGOs to partner with governments in these places. I was wondering if you could speak about a little bit about the difficulties in partnering with governments.
Let me count the ways. It's also incredibly rewarding. I mean, that's what I should start with, because when you see things that actually then take shape, it's incredibly rewarding. And you know, people don't go into government because they want to hold things up. They go into government because they want to make change and they want to help large groups of people. And so there's no question about that. I think that some of the things that tend to make it difficult is that, you know, they are bureaucracies. They have to run under sort of specific budgets, and they often change. The people will actually, you know, be elected in and out, and just when you finish making a great relationship with someone, they leave, or they're asked to leave, or something happens. Sometimes they don't. We have a district health commissioner in central Haiti that we worked with over like 7 governments. I mean, he stayed the same. I mean, it was like, yeah. So it's difficult to get things done. But I think, you know, to Alison's point earlier, there is an absolute, there's an antipathy to working with local governments. We are so used to being able to just go into countries and say, I think you need a school. I think you need latrines. I think you need some trees. I think, you know, we'll just come in. And there's a well-meaningness, but it's a great entitlement to just walk in somewhere and say, here's what you need. And just try and imagine doing it in Wellesley. You know, oh, I've noticed there's a little blank spot here. I think I'll plant some trees. Try it. See what happens. Good luck. And I think that's the case in a lot of places. So you have a stronger government, as there is in Rwanda, who's been very specific about regulating the NGOs there. I mean, it happened after, you know, I think that at one point they had more NGOs treating HIV, more NGOs treating HIV, the whole NGO, than people on HIV treatment. I mean, it's a craziness, the swirl that can happen around some of this NGO stuff. And then you have small NGOs who are church groups from here who want to go down and provide dentistry to different groups. And I've spoken to many of them, and they're like, please, honestly, it's hard for us even to talk to the head of the local church without feeling like we, you know, it's just more complicated. So, but Haiti, I think, has the most number of NGOs anywhere in the world except for India, which is over 10,000 of them working. So you can imagine the swirl of activity around all of this kind of thing. So I just, you know, being able to do that is very important. It is complicated because then if you don't necessarily have a precedent. So that's the whole notion of accompaniment, which I didn't talk much about, but accompaniment takes place at many, many different levels, including our ability to sustain a relationship over a long period of time and not to give up or to throw up our hands because a new leader changes or something else changes, but to be able to actually inculcate it into a Ministry of Health. If you're going to change a medical education system, which is also part of the problem, you know, the medical education is really just not robust at all, and often doesn't have anything post-graduation. There's no fellowships, residencies, anything like that. So you have to be able to, you can't then start a medical education system from Boston alone. You have to get in touch with people in the nursing schools that are public and medical schools that are public, and provide money for that and ask them what they want and how they need it. And you have to think about what languages that they want to teach in. Creole, French, English, you know, there's all of these different things to consider. So it's just, it's a long list of different things, but it's incredibly rewarding, and it's the way it will stick for the long term. It's actually the answer to sustainability and scale. You got to build up the public sector.
Please join me in thanking
Thank you.